we're very lucky to have here. He doesn't need any introduction at all. We're very happy to have here Professor Choudhary with us. He's a professor in diabetes at Leicester. He's a fantastic researcher. You all know that. He has like hundreds of papers regarding diabetes technology, hypoglycemia, education, psychology in type 1 diabetes. He's a fantastic speaker. You also know that. And what I can add is that he's an excellent clinician. I had the opportunity to work with him when he was at King's College in London, and he's very close to the patients and wonderful. So he's gonna talk about the importance of hypoglycemia prevention. So thanks for being here face to face with us.
Thank you. And I was gonna say, I'm very lucky to get fantastic people working with me, including Pilar, who came back twice to work with us, and fantastic carrying on your work here in Spain as well. So when Pilar said, will you come to this talk? Of course, I cannot say no. But then she gave me a topic which I thought, this is very strange. Everybody knows how important it is to prevent hypoglycemia. So what can I say that you do not know? This is very difficult. She was really testing me when I came here. No easy talks of how to prevent it, how to use technology to reduce hypoglycemia. No, that she kept for herself later. These are my disclosures, so let me give this a try. So why is it important to reduce hypoglycemia? And I think the first question, which might be a very odd question, is in the age of CGM, what is hypoglycemia? Or maybe I can change that language a little bit to what is clinically important low glucose. Yeah? So I'll talk a little bit about that because I've spent the last 3 years trying to understand that question. And actually, I'm going to show you some data that I saw for the first time from my team yesterday in Copenhagen. And then, what is the impact of hypoglycemia? And we can, again, I'm part of a project called HyperResolve, and we are evaluating the impact of hypoglycemia. And broadly speaking, you will understand there are 3 areas. It impacts the physical being, reduced awareness, confusion, but also maybe inflammatory process. It involves an emotional impact, fear of hypoglycemia, depression, and then there's the social impact. And then fundamentally, if we can understand that impact and reduce it, we can improve the lives of people living with diabetes. Yeah. So when we think about hypoglycemia, in the past, we had level 1 hypoglycemia at 70, level 2 at 54, and severe hypoglycemia. But with the age of technology, we have some different levels of hypoglycemia. So you see the person with a glucose, maybe 80 or 90 even, slightly higher than hypoglycemia, but the arrow is going down. That person does not have hypoglycememia, but he has all the impact of hypoglycemia, anxiety, annoyance, inconvenience, at above 90, right? So maybe there's one slide missing. Once you hit the alarm, you might set your alarm at 70. When you hit that alarm, then you might start getting the counter-regulatory response. And then when you get down to 50, you then start getting cognitive impairment, inflammatory response, platelet activation. With prolonged events below 50, you start to get blunting of your symptom and counter-regulatory response to the next event, right? And then it's when you get prolonged events down below 50 that you end up with the difficult areas with cognitive dysfunction, loss of consciousness. And understanding these different levels of hypoglycemia becomes really important, because I find myself having conversation with people. I had a patient last week who's newly diagnosed with diabetes, and he works as on a building site, having to climb up on buildings and scaffolding. And he says, I don't take insulin when I'm at work because if I go below 70, I will fall off the roof and die. Is this true? That's what he thinks, but is that true? Is his belief true? No. Because if he goes down to 70, he will get symptoms. He will feel it, he will treat it, he will get on. To get cognitive impairment, he has to be below 54 for a long time. But his sense is going to beep and alert him at 80, at 85. So his risk of falling off the roof and dying is almost 0. His fear prevents him from getting control. And this guy had an A1C of 13%. And lack of knowledge of what those different levels, lack of explaining. Because in a rush, our educators tell you, what do they tell you? I had another patient on a closed loop who the alarm was set at 70. And every time the alarm goes off, which is once a day, she felt, she had been told, if you go hypo, you might lose consciousness and you might die. So the emotional response was, I have cheated death. Every single time the alarm goes off, the whole family panics. And you just explain to her that actually, to become unconscious, no one really knows how much hypoglycemia you need to lose consciousness. There's only one paper I'm aware of that came from pediatrics, from Bruce Buckingham. And in that paper, there were 4 children who, when had blinded sensor, had seizures. And all 4 had been below 2.2, below 40 milligrams for 2 hours before they had a seizure. Right? So, and we've all seen, have you all seen traces where the glucose is flatlining for the whole night and the patient wakes up the next day? If that causes death, I would have no patience. So the body is incredibly resistant to low glucose. So we have to tread this fine line between we want to prevent hypoglycemia. Some hypoglycemia is really dangerous, but most hypoglycemia is inconvenient. And I think that's a big difference. That's the kind of first thing when I'm thinking, what is hypoglycemia? Hypoglycemia is below 70 is not hypoglycemia. Below 70 is an alert value. All the negative biological impact of hypoglycemia happens below 50. We set the alarm at 70 to prevent the 50, but then we start setting the alarm at 90 to prevent the 70. And then the patient says, I better stay above 110 to prevent the 90. Right? And we're leaving time and range on the table. So that's kind of my first thought. The second thought is, as we get more and more CGM, I was involved in this paper, this study comparing degludec and Toujeo. And in this study, they used blinded Dexcom sensor for their outcome. And on the blinded Dexcom sensor, if you look at below 70, 7.8 events per week. Yeah? More than 1 per day, below 70. But patient-reported events, when they had to fill in a form at the end of the week, how many hypos have you had? 2.5. They excluded hypo-unaware patients. These are hypo-aware patients, but they only feel 30% of the events below 70. So maybe they're better at feeling events at 50. No. Below 50, 3 events per week. Symptomatic, 0.6 events per week. You only detect 30% the time you go below 54. Why do you only detect those 30% events and not the other 70% events? Is it rate of change? No. Because we've looked at that. So to answer that question, a brief plug here for a study called Hypometrics. So we recruited 600 people, and they all wore a blinded Libre sensor. They all wore a Fitbit, so I knew when they were sleeping in gray and when they're awake, because all the data just calls midnight to 6 o'clock sleeping. Now, I'm often awake till 2 o'clock. I think in Spain, you don't sleep at midnight, right? You're late, yeah. So those timings are arbitrary, made up, right? So when we have technology to tell when is a person sleeping, when they're awake, because we all know from our experience that when the patient is sleeping, you need to be lower for longer before you're symptomatic. And the reason for that is because when you're asleep, your counter-regulatory response is really small. That was proven in the 80s, right? And then for 10 weeks, every day they filled in this app, and on the app, every single time they had a hypo, they said, I've had a hypo, and they recorded all the symptoms, what the glucose was, and we even got data on how long it takes them to feel okay. Some people say I feel okay in 5 minutes, some people say I feel tired for the whole day, right? We've got all of that data, and so that's what we've been looking at quite carefully. And you can see here, this is the glucose trace, that is the step count, that's the heart rate. These are hypos that the patient did not report. These dots are the ones where the patient said, I felt the hypo, right? And we had 600 people with type 1 and insulin treated type 2. We've got 40,000 days of data, which is about 102 years worth of CGM data. And we've got 30,000 events below 3.9 at about 4 per week. 6 per week in type 1s, 3 per week in type 2s. Okay? Median duration of each event, the median duration is 60 minutes of every hypo. We have 7,500. Look at the difference. You could argue if you set your alarm at 3.9, you're going to get 1 event per week. If you set your alarm at 7.5, you're going to get less than 2 events per week. Just putting your alarm down will halve the number of alarms your patient gets and the interference on their life, right? Again, median duration of those low ones, about 40 minutes. I literally got this data yesterday. And below 2.2, the ones that really cause harm, in 102 years of CGM data, we had 302 events. They are incredibly rare. Probably, and half of our patients were using, they had a blinded sensor on one arm, and they had their own sensor on the other. And half the people were still using finger prick, particularly the type 2s, right? And we had 15,000, of those 30,000 sensor events, we had 15,000 where the patient said, I felt hypo. Half, right? Maybe not. Because how do they relate? That's our 30,000 sensor-detected hypos, and that's our 15,000 patient-reported hypos. Half the events the patient said I'm symptomatic for, the sensor glucose was not below 4. It was higher, 4, 5, and 6. And they're feeling symptoms, they're reporting symptoms, and they're treating it as a hypo. And the blinded sensor says they're not even hypo for 50% of the time. If we look at the events at 3.0, you can see again a similar split with only half of them being asymptomatic, half of them being symptomatic. And so, if you define, we ask our people, if you want to assess awareness, you say, how often do you find what you do know when your sugar's 3? I now think that's not an intelligent question, because they don't know the ones they don't feel, right? What we found is in type 1s, you pick up about 30% of your hypos. If you're type 2, you only pick up about 20% of your hypos at 3.9, and at 3.0, it's again about 40 and 20%, so very similar rates. So what we understand is sensor-detected, asymptomatic sensor-detected hypoglycemia is incredibly common. It is normal not to feel all the lows on your sensor, right? I get referred a lot of people. I do a lot of driving assessment. And in England, you have to have an assessment for driving lorries. I don't know if you have that in Spain. And you have to be hyper-aware. And I get people referred to me saying, on this sensor, the patient did not pick up all their hypos. He's unaware. I banned him from driving. He's lost his job. Confusing data, but this is the first time it's been done. So hopefully now I've confused you as to what is hypoglycemia, or what is clinically relevant hypoglycemia. Maybe we should look at the impact of hypoglycemia. So what is the impact of hypoglycemia? So again, as part of our HyperResolve project, we did a huge survey of a few thousand people and looked at the questions. And so you can see here, there's lots of different areas in which hypoglycemia affects people. There's a negative impact of hypoglycemia on all of these domains. And broadly, it's physical signs about women health, sleep. There's psychological aspects about emotional well-being, energy, ability to keep active. And then the social stuff. People restrict their activity because I don't want to have a hypo, so I'm not going to exercise. I don't want to have a hypo, so I'm not going to drink. I don't want to have a hypo, so people restrict their activity. So that's the social aspect of this. But is there an impact of the asymptomatic events? That I said 70% of the events were asymptomatic. So what we did is, every morning when they woke up, we asked them, how sharp are you feeling? What's your mood? And how well did you sleep? And they had a blinded sensor. And so you would expect if they had an asymptomatic hypo, low sensor overnight, maybe they felt worse, right? So the first column A is what they scored on the days when there's no hypo. So that's their average score. If it's a very happy person, they will score high on mood. If it's just a grumpy old person, he'll score low, right? B is what happens when there is a sensor-detected hypo, but no symptoms. No difference. No difference at all. The other two columns are when they have a patient-reported hypo with or without sensor hypoglycemia. So it doesn't matter if you're actually hypo or not. If you think you're hypo, you have a 5% reduction in quality of life. And actually, we saw the same reduction when they're treating when they're preventing hypo. So all this is, we've differentiated out. Did you prevent a hypo? Did you treat a hypo? Did you detect it just with your sensor? Or did you detect it because of symptoms? And it turns out that if you detect it, if you're asymptomatic and because of the alarm, it's a smaller negative impact, but if you're symptoms, it's a bigger negative impact. So it makes you think, if we're putting the alarm at 3.9, at 70 or 75, you're giving a lot of alarms for things that would have been asymptomatic. And that means you're giving them a lot more hypos, which has a negative impact on their quality of life that they wouldn't have had they not been alerted to those events, certainly between 54 and 70, right? The question is a bit different once you get below 54, because once you hit 54, you get cognitive impairment, you get inflammatory responses, so the story below 54 is very different. And those events below 54 that you're not picking up do have a negative impact, biological, by preventing your response to your next hypo, by causing cognitive impairment, and maybe by causing vascular inflammation. When you see this sort of hypoglycemia, I think all of us think about what is the cause of these hypoglycemia. What Pilar did not give me time to talk about was the fact that when you look at your therapy setup, too many times, generally when we're looking at diabetes technology, pumps, sensors, even closed loops, and we see a data slide, our main focus is adjusting the dose of basal insulin, the dose of basal rates, to fix the problem. And sometimes the doses are the reason for the problem, but more often it's the behavior of the individual. So this can be coming off, actually, not excess background insulin at night, but excess correction at bedtime, right? And so one of the things that I always teach when I'm saying looking at the data is think about what's because of structure and what's because of behavior. And we spend 90% of our time adjusting structure in response to behavior. And I've made looking at these downloads very simple in my clinic by saying that the structure is fixed by Pratik's rules. And Pratik's rules are very simple. You calculate the total daily dose of your patient, and you make sure that your basal is 50% of that dose. Right? And if this guy's basal is 50%, then it is correct. But if this guy's basal is 70%, then the basal is causing the hypos. Right? And you don't reduce it by 10%, you just make it 50%. Right? The carb ratio is fixed at 350 divided by total daily dose. And so we don't spend time, I'll just change your carb ratio from 8 to 8.3. It doesn't happen in my clinics anymore. It's 350 because it's 350 divided by total daily dose. The correction factor is 2,000 divided by total daily dose. Right? And what you do is that means that your basal, your carb ratio, and your correction are in balance. And that means that now, once you put them in balance, you can focus your time on the behaviors like post-meal bolusing, overcorrecting, not correcting highs, over-treating the lows, that we don't get time to manage because we spend all our time saying, if I change your tracebo from 20 to 21, all your problems will be solved. Yeah. And then the patient comes back and they see the next doctor who says, it's 22, it's too much, we make it 20. And then they come back the next time and it's too little and we make it 22. And for 6 years, the dose has been going up and down. Yeah? It happens in I did this for 10 years. I'll change your basal rate from 0.65 to 0.675. So when we looked at it, and actually and now we can focus on getting the behaviors right, because if you think logically, the dose of any dose you make is wrong, because every day you need a different amount of insulin. So let's do some basal testing. So if I did some basal testing today, it would reflect another day when I've landed at 1 o'clock in the morning and then there'll be no food here. I have to buy, and then you wake up and you go for a run in the morning, which is a completely different life than tomorrow when I'm in the ward in the hospital. So I mean, a lot of these things are in the fabric of how we should do diabetes technology, which don't make any sense. Right? And so if you're going to adjust basal insulin, for example, I'm going off piste here, but my thinking, you're right, has changed a lot since you're with me. You should give, we always prefer twice daily levemir as our basal, because we know that people's overnight basal insulin requirements are different every day. But not everybody changes it. So if someone's going to take 12 and 12 of levemir, why not give them 24 of Tresiba? It doesn't make sense to make them take an extra injection. But if they are going to change it and say, on the days that you drink alcohol at night, drop your dose. On the days you have an Indian meal, a Chinese meal, pizza, or high cheese fat, increase your dose of basal by 25%. If that person is going to do that, then they should be on twice daily levemir. Tresiba is rubbish. In that scenario. And the other one that I've made up, and I need some evidence to prove this, is that, like I know my step count, my average step count is about 8,500. But if I were to do 3,000 steps, I should take 20% more insulin that night. Because if I've been sitting on a plane and being stressed and done 3,000 steps, that night I need more insulin. But if I've done 18,000 steps, I should take less. That's because we see from the closed loop studies that the variability of what the pump gives you varies by 200%. So you can apply some of that to your MDI patients, those who will. Most won't, and if they won't, give them once daily basal. So think about the cause of the hypos. Think about, is it structure or behavior? Fix the structure, then you know it's not the structure. And then you can focus on the behavior. What can I do to help the person with diabetes reduce them? Is there any technology, education, knowledge that we need to give? But then also, what is the impact of those events? And we didn't, once you start asking about these, you start realizing what they think will happen if the glucose goes below 70 might not necessarily be true. And so we can reduce some of the anxiety, some of the psychological impact of hypoglycemia by giving people the right information. So matching the treatment of the patient. This was a paper we published actually when Pilar was working with us, and actually Pilar co-authored this paper here, which was a systematic review of all the education programs to reduce hypoglycemia. And if you just give the patient education, you reduce about 50% rate ratio of hypoglycemia. And that's always a first step. Second line, it's really CGM now. I think the data shows that CGM as the next line reduces hypoglycemia much more than pump therapy, much faster than pump therapy. And our national audit shows a huge reduction in severe hypos just with Libre. And automated insulin delivery, I was involved with the SMILE study, a randomized controlled trial in high-risk patients, where, interestingly, the important factor here was that we took people with high risk, impaired awareness or previous severe hypos, put them on 640G. Their resultant rate of severe hypoglycemia was lower than people with normal awareness using CGM alone. So you can take the high-risk population and put them to a risk lower than the background with these technologies. And finally, these are the data from HeartDoc. This is the paper in Nature Communications showing the reduction of severe hypoglycemia with the psychological intervention. And then in the UK, of course, we have this final line of therapy, which is transplantation. I mean, I ran the transplant unit for 10 years, and in 10 years, I transplanted 10 people. It was the 10 people who were not fixed by all of these things, generally because their psychology was too bad and would not accept those treatments. And those people were transplanted. And I want to end up with just two slides on type 2 diabetes. And this is a really, really important slide. It's not a very important journal. But what they did was they took everybody who had an ambulance call out and they put them in an observational study or an interventional study. And the intervention was monitor your glucose twice a day, weekly contact from a nurse for 1 month, and then 2 weekly for next month, and then 3 monthly, and check your bloods, structured education, and de-intensification of inappropriate drugs. Stop the SU, consider, that sort of thing. And this is the only hypoglycemia study to show a 50% reduction in mortality at 1 year by a very, very simple intervention, which was just get a nurse to call them weekly, 2 weekly, 1 monthly. So I think it is unethical not to implement this study in our clinical practice and identify people. So finally, CGM and time and range metrics give us a very detailed insight into the frequency and quantity of hypoglycemia, but we have to now understand hypoglycemia in 2 dimensions, depth and duration, and think about the different impacts of those. With modern technology, we know that the rate of hypoglycemia can be reduced, and we can optimize those therapies to reduce that. And with that, we need to kind of have this holistic goal of reducing the physical, psychological, and societal impact of hypoglycemia on people living with it, and maybe reduce the negative impact of fear of hypoglycemia at the same time. Thank you.
Thank you very much. We don't normally take questions after the opening lecture, but I think we cannot miss the opportunity of having Pratik here with us. So if you have any questions or comments in English or in Spanish, Ana Chico.
Thank you very much. Do you think that we should only pay attention in the proportion of time below 54 and not the time below range of 70?
So yeah, really good question. Because, so let's think about the answer to that. I don't have a clear answer to that because I say I've only really seen these data in our study data, the kind of full data set. But 30% of those events, so let's stratify that answer. Events which the patient feels, irrespective of the glucose level, have an impact on that individual, right? So they are important. So it's not to say that events that patients are symptomatic with between 70 or between 90 and 54, they have a negative psychological and a negative societal impact.
But
right?
Maybe we can improve that with psychology.
Yeah,
Teaching
and
them to
so we can reduce the psychological burden of that, for sure, right? But what we're doing is we're increasing the proportion where that negative impact is by having alarms that are set quite high with technology. So, and then there is and I think, yes, I think below 54 is definitely way more important, right? And IHSG say 70 is an alert value. So I kind of say to people, when I'm driving along the road and there's a little kind of, there's a cliff and there's a barrier. 54 is a bit like the cliff, right? When I hit it, something bad's going to happen. I'm going to get a scratch, a scrape, or if I hit it very hard, maybe worse. And 70 is a bit like that red line near it, which buzzes, and I buzz it, I feel, oh, I'm getting a bit close, and I go away. It's an alert value, but nothing harmful is going to happen. And the other thing I've started to say that's different based on these data is, I showed you the first slide. I showed the glucose coming down, and the glucose might be 85 with a down arrow. And the patient sees it, and we always teach, if you see any reading between 6 and 4, what's 6? 6 is, between 6 and 4, and you're dropping, then treat it with 4 to 8 grams of carbohydrate, prevent the hypo. And we're saying prevent the hypo. And what we're learning is the negative impact of prevent the hypo is the same psychologically as having the hypo. So I've changed my word to say, and straighten the line. If you're driving along the road and your car is going to the edge of the road and you straighten the car, you don't say, oh, I just avoided the accident. You say, I straightened the car. So why don't you straighten the line, don't prevent the accident. I don't know if that makes any difference, but yeah. Does that answer your question a little bit? Yes. Thank you.
Martín.
Thank you very much for an excellent talk. I was thinking as you were presenting your data that perhaps the time of the day that the patients are reporting the symptoms that might make a big impact in terms of, I don't know if you thought about the fact that the patients are bolusing or giving injections just for meals, and as the blood glucose is going low very fast, how to define hypoglycemia in that scenario might not be the same that compared to the rest of the day, for instance, at night. So my point is if there should be different definitions according to the time of the day, and taking the consideration that you recently injected insulin, rapid insulin.
So really great question. And again, I have enough data from HyperResolve already to fill in 2 hours here. So we have looked at day versus night, right? And so in the day, you of course lower for longer before you feel symptomatic, and the average time before people are symptomatic is about 70 minutes at night. We have also looked at rate of change, thinking that, so we've divided every single hypo, all 30,000, by whether the rate was coming down by less than 1 milligram per deciliter, 1 to 2, over 2, and seen, because we can not only see binary, whether they're symptomatic or not, but we can also talk about the intensity of symptoms, because they mapped which symptoms they had and how intense those symptoms were. And there is no correlation. There is no correlation between rate of change of glucose and the symptoms people have, at least on our initial analysis. You'll see those coming at the conferences coming through later on, and we can do some cleverer things about that. We can't tell the boluses because Novo couldn't give me connected pens in time for this project. But rate of change governs it. So, and I think what you're getting though, the reason why patients say that I know when my glucose is falling rapidly, they don't know how many times the glucose fell rapidly and they didn't feel it, right? But there's a positive psychological association. And if you're living with type 1 diabetes and your glucose is 350 and you took a big bolus, you know you might be going hypo. So you're more vigilant. And then you see the rapid rate of fall. And so you may be more aware of the symptoms. So there's some learned response there for those lows that you have created because you know it's going to happen. That's my prejudice to some extent.
Just to add, the other thing I was thinking is, how are we going to translate this into educational programs? Because, as you know, we are very, very used to teach the patients that 70 is the alert value that they should be. So changing that to 60, for instance, that seems to me like a big change in our reality at the moment.
I think I have to be really careful when I talk about this, because I wouldn't change my current advice, which is if you're between 90 and, or even 107, between 100 and between 70, and you're going down, take 5 grams of carbohydrate and straighten your line, right? This information does not change that advice. What it changes is, yeah, sometimes you go down, you won't die because of it. It's okay not to feel all of them, and they will happen sometimes, but the ones you see, you should prevent. It's a slight, can you see, so I'm not saying, hey, if you're 62, 63, don't do anything. If it's going down, yes, you should get yourself out there with our time, and we want to stay between 70 and 180, but it's about being slightly less worried that as soon as you go, a bit like, it's the same thing. Some of the very highly anxious people feel that if their glucose goes above 180, if their time in range, if they go above, oh my God, they'll come and say, Doc, my sugar was 140 that day, or 220 that day, and I was really upset about it. And I'll say to them, so your brain catastrophizes and thinks that if your glucose goes to 220 once, your eye will explode and your leg will fall off. I say these words because then they laugh. But they realize the exaggeration. I'm exaggerating their feelings, but they're exaggerating the reality. And similarly in hypoglycemia, we are slightly exaggerating the negative impact. People still feel symptoms between 70 and 54, and so it's important to prevent those symptoms, but recognize them for what they are.
Thank you.
So it's a difficult
it makes sense.
line,
Makes
yeah.
sense, yeah.
So thank you for this excellent talk. We really enjoyed with all these ideas, and new ideas. And related to patients with fear of hypoglycemia, we know that technology could reduce the rate of hypoglycemia, but I'm not sure, and we know that it doesn't reduce the fear of hypoglycemia in a big group of patients with these symptoms. So my question is, how quick could we manage this fear of hypoglycemia, and can we plan of any structured programs mixing educational and psychological advice? I'm not sure how to manage these patients.
No, I think you're really right, and that's that's an area that has not been researched or acted on at all. There is no program to reduce. There are programs to reduce hypoglycemia, and you can reduce the part of the fear that is due to inappropriate information. So when you take that group who have low risk but high fear, right? Some of that fear I've seen reduced by clarifying, so what are you scared about? I'm scared of hypos. What are you scared about? What will happen if you go to 70? What do you think will happen if you go to 70 to 60 to 50? And you talk that out, and you understand, and you can see that fear of hyper going away. But there's part of that fear, that is, what's the word?
Not rational.
Irrational, correct. So Pilar knows I have an irrational fear of going on the tube in London. I know if I go in the tube I will not die, but my brain feels that way, so in 10 years I have not been down the tube. I can't get myself to go. So I understand living with irrational fears, and that's harder. But with HARP-Doc, we have managed to treat, to some extent, the irrational fear of hyperglycemia. And so I'm hoping we can use some of those principles to now look at fear of hyperglycemia as well. But yeah, there's nothing out there. It's an area to expand into. It's an open goal.
So thank you very much, Pratik, and thank you to all of you for your participation. We have to close the session, unfortunately. Thank you very much.
Thank you.